here to give you a whole bunch of information, some of which you may have heard before, some of which may be new, and I'm going to preface this by saying this information is valid as of 8:40 a.m. this morning. Come 10 o'clock, it could all change. You laugh, but it's true. There's actually a seminar, a webinar, a final webinar tomorrow that the Department of Medicaid is putting on that we could learn how everything that we've been planning for and are ready to implement is going to change. So with that being said, take this with a grain of salt. We're going to ask for your patience that you roll with these changes as they continue to change, and as we eventually go through with it on January 1st, we may need to adapt. We think that something is working, and in fact it's not. Change will happen. So today what I'm going to talk about roughly for the next hour and 15 minutes is about all the different changes that are coming down the pike for us. And for those of you who haven't heard about BH redesign, is there anybody in here who has no knowledge of it whatsoever? Okay, good. So a lot of the information that I'm going to start out talking with should be a review. And then hopefully we can transition into some general information. Now, what the overarching plan will be is that today is the general overview. And then next week, myself, Shelley Schoaf, and Val Colvis, who are sitting back in the back corner there, and we need to give them a round of applause because they have been working tirelessly to get stuff done to make this work. We couldn't do what we need to do without the hours and days and weeks worth of work that they have been putting in and will continue to put in. The three of us in some combination are going to be coming out to your various staff meetings next week to talk about some of the specifics about your individual program and how the pragmatic day-to-day kind of stuff will work. Today is just more of an overarching overview of the concept so that you understand the foundation that we can build upon next week. So one of the things I wanted to start out with today is this phrase that I have heard quite a bit. And well, this is the way that we've always done it. Sometimes it feels very comforting, yes? This is the last time you get to say it, because the way that we have been doing business for the past umpteen decades is gone. Ohio is the last state in the country to go through this behavioral health redesign. We were supposed to do it back in 2013. We kept getting extension after extension after extension, and eventually the federal Department of Medicaid said enough is enough. Get your ducks in a row, make it happen. Of course, we were supposed to do this in July, but there was a number of technical difficulties with the billing end of it, hence why Val and Shelley have been working tirelessly, because as of now, and correct me if I'm wrong, ladies, it's still not working 100%. They are going through beta testing of all the billing software, and out of, I want to say, 225 providers that are involved in the testing process, only about 25 have been successful. So there's a lot of work that's going to be happening over these next couple of weeks to make this become a reality. But similar to what happened, I think, with the OTP programming, there's going to be bumps in the road. So this whole notion of this is the way we've always done it, you need to kind of get that out of your mindset now and be prepared to embrace something new. So all of these slides that I'm showing you are going to be available on the share drive once everybody's merged. So you won't need to necessarily take a lot of notes. Our goal today is for you to hear the information and to understand it. But then you'll have this as a reference point down the road. That this BH redesign is part of an overarching goal for the Department of Medicaid Services. And this is so important because out of all the funders that we have, Medicaid is our top funder, as in most community behavioral health providers. And since they are our top funder, we have to adapt to them. And what will make this somewhat confusing for all of us is that Medicaid is going to be doing things differently than other funders, such as commercial insurance. Down the road, I would envision things will start merging to be similar, but nonetheless, commercial insurance and Medicaid are still doing things differently. So those of us who are direct service providers will need to kind of split our brain and think, okay, which client am I serving? Am I serving someone with Medicaid or am I serving someone with commercial insurance? Because that will definitely make things different in terms of how you document, how we bill. So this process is really part of an overarching goal that also includes what's called carving in managed care for Medicaid. That's not going to happen until July. But once that happens, the managed care companies like Buckeye and CareSource will be monitoring our services like a commercial insurance company does. And there will be reviews and there will be potential denials, all involved in this managed care process, all to make things more efficient in terms of service provision. So this is just the first step of changes coming down the pike. So it's also part of a modernization process that we as a system are going to provide more efficient services and do it according to new administrative code rules that will go into effect January 1st. And this has actually been going on for quite some time. And like I said, the new code set that's going to be going into play for BH redesign starts in a couple of weeks. The carve-in process then will start in come July. And again, these are non-negotiable at this point. Now, these codes are part of a national initiative, National Correct Coding Initiative, I believe is what it's referred to, so that we are similar to every other state in the country, so that we're no longer the outliers. So everybody else in the country is doing it this way. We need to catch up with them. And it involves not only doing things the way that everybody else does, but matching the code to the exact type of service that we're providing so that the claim that goes out, everything matches on that front. Now, part of this BH redesign is about Medicaid expansion of services and reorganization of services that we're already doing. So, previously, Medicaid recognized these 9 services. And I know these screens are kind of hard to read with the font. These are some of the official slides that the Department of Medicaid has put out. So we're talking about services such as mental health assessment, farm management, partial hospitalization, crisis intervention, respite for children, mental health counseling, CPST. Because of the changes with BH redesign, it's being expanded significantly. And some of these services are being renamed. So for example, partial hospitalization is now called day treatment. They are also offering additional types of services that we'll go over briefly called therapeutic behavioral service and psychosocial rehabilitation. There's also psychological testing, something that Medicaid has not paid for in the past, or an expert screening, which is something that is primarily in primary care medical world in terms of screening for AOD-related issues. So you can see there's a lot more options available to us once these changes go into effect. The changes not only affect the mental health spectrum, but they're also affecting the AOD spectrum. And they're focused on the ASAM levels of care, starting with outpatient services all the way up through detox services and everything in between. Here in Ohio, you may have heard us talk about that we are supposed to follow the ASAM criteria. Unfortunately, because of some copyright-related issues, nobody in Ohio is using the ASAM levels of care yet because ASAM says we must pay them a lot of money to be able to use it. So that's a battle at the state level beyond this discussion. But nonetheless, this BH redesign is impacting both parts of our organization, the mental health and the AOD world. So when it comes to the substance use levels of care, previously it fell primarily under 2 categories, outpatient and residential, with the various levels and services underneath each of those categories. Now they're expanding it to make IOP its own and offering a new level of care, partial hospitalization. That's not something that we as an organization are going to be doing. However, it is something that's available. So now we have a new level of care above and beyond IOP that Medicaid will now recognize. All right, any questions so far? I haven't lost you yet. I don't see any heads falling down on the table. That's a good sign as well. All right, so in order to understand some of these concepts, I want to review real quick some of the basic terms that go along with BH redesign. Coding, you may hear finance people talk about HCPC codes and CPT codes and add-on codes. These are the codes that they are using that are generated behind the scenes and are built in to your SIM codes that you are using in your documentation. And one of the things that we're going to be working on as these new SIM codes go into effect is explaining to you how the SIM code itself is defined and how it's conceptually made up so that you understand and are able to select the correct SIM code. Because as Michelle referred to earlier, the number of SIM codes that you are going to see on your templates is going to at least triple. And again, that is because of this BH redesign, as well as how NextGen and Topaz works on a programmatic level with computer programming. So HCPC codes are used to bill Medicare and Medicaid. And they usually begin with an H, an H000. And you've seen them all the time. So for example, H0015 is group counseling at the IOP level of care. CPT codes, which stands for Common Procedural Terminology, are another name for them is a level 1 HCPC code. These are codes that typically begin with a 9. For example, 90791, the psychiatric diagnostic evaluation that we do for our comprehensive assessments. There's a new type of code that's coming down the pike for us, which is called an add-on code. And we'll talk about interactive complexity in a little bit, but that's an example of a new add-on code that we will have the ability to also select within NextGen. It's a code that describes a service that's done above and beyond the normal HCPC or CPT code. There's also differences between what we do as counselors and what the medical staff will be doing in terms of their E&M codes. You may hear some of the medical staff realize that their new patient is someone that they have not seen or the agency has not seen in the past 3 years. That's under their rules. Under our rules, we can only provide one assessment per year, per patient, per provider, and when I say provider, that's all of us as an agency. For the medical staff, they also refer to an established patient, and that's someone who's following up with care or who returns within 3 years. Whereas for us, we would be doing an assessment that's billed as an individual counseling session if another assessment had been done within the past year. So the rule that for you all to remember is that we can do one assessment per year per patient. So for example, if somebody at the Cleveland Avenue site is wanting to go out to one of the residential facilities, the outpatient site will do the diagnostic assessment, the comprehensive assessment, and then the follow-up over, let's say at Wilson or Deliverance, would be an individual counseling session to do a second assessment as needed. But it would be billed as individual counseling. That is our only option at this point. Another concept that is going to be new for all of us, and some of us have already gone through it, is what's called provider enrollment. Medicaid is expecting all of us as licensed practitioners, and even now the unlicensed practitioners, will become enrolled in Medicaid so that our enrollment information goes out on the claim behind the scenes. The expectation is that those of us who are independently licensed should already be enrolled or be enrolled by January 1st. Is there anybody here who's independently licensed that has not coordinated with Sandy Brockway, to get enrolled in Medicaid? Good. For those of you who are dependently licensed, we are expected to get you enrolled by July 1st. So Sandy will be coordinating that effort as well to get you enrolled in the Medicaid MITS portal as well. But this is also going to include case managers, peer support specialists. Anybody that's providing service will need to be enrolled with Medicaid. And that's what these next slides are talking about, how the independently licensed clinicians are expected to already have this done. And what's amazing is Val and Shelley and I have gone to seminars with agencies around the state, and there are still some providers who haven't been enrolled yet. It's almost as if that they're an ostrich and they buried their head in the sand thinking, oh, this won't come, so I don't need to do it. La, 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 kind of thinking. It's coming. So again, all the paraprofessionals and what's called the BHPs, these are the trainees and the assistants. And this category, you're going to see as we go through this information, is the one that's most impacted. So our interns, our CDCAs, any student, these are the ones that have the most complications associated with BH redesign. There's another concept that comes with these new codes, because a lot of our codes are time-based or have been time-based. Eventually, our codes, most of them, will be encounter-based. And in order, meaning you get paid for that encounter. Regardless of how much time you spend with the individual, this is how much you get paid. It's part of the reason why the change was made for the comprehensive assessments to do it all in 1 hour. And I'll show you a slide here in a little bit that will explain some of the math behind that. But part of this coding process has to do with the rule of halvesies. And what that basically is saying is that the encounter code that you will be picking, you need to meet with that individual for half of the time plus 1 minute. So if the code is for individual psychotherapy for 30 minutes, and that's the lowest level of psychotherapy, is my understanding. Correct, ladies? Okay. That you need to meet at a minimum with a client for 16 minutes. So the whole notion of doing a therapy session in 8 minutes is now gone. Because the rule of halvesies says you must meet with the individual for half of the time plus 1 minute. So if you look at a 15-minute based encounter, like therapy, this chart will kind of show you how it breaks down. Another concept that you are going to hear quite a bit, and you may have heard a little bit so far, is the differences between general and direct supervision. How many have heard of this so far? Okay. What you may have heard is that it applies to everybody in this room. Well, that has since changed. It now only applies to trainees and assistants. So if you are supervising a counselor trainee, a social work trainee, a marriage and family work trainee, or a CDCA, or you are one of those licensees, this applies to you, and applies significantly because it has to do with pay differences. You may have also heard that the difference between general and direct supervision, they were blurred boundaries before, but it's now been very clearly delineated. General supervision applies to your supervisor is available to you in some capacity, usually off-site, probably by phone. Direct supervision means that your immediate supervisor is immediately available and readily interruptible, must be on-site. So for example, those individuals who are school-based counselors, there's no way that your clinical supervisor is on site with you. You might be the only person at that school, correct? So by default, if you were a trainee or an assistant, by default, all of your service would be general supervision. If, however, as a trainee or an assistant, your clinical supervisor is there in the building and readily available and interruptible, that's the threshold. We can then bill for those services under direct supervision, and it makes a difference in terms of the payment. General supervision is paid at 72% of the supervisor's rate. Direct supervision is at 100%. So we as an agency have an expectation of you as a trainee or as a supervisor of a trainee to do everything possible to ensure that direct supervision is available. There are going to be times when it's just not possible. For example, with the school-based counselors, it is just not possible for a clinical supervisor to be out on site. It might be physically impossible at some of the other sites, depending on certain circumstances. But whenever possible, our goal is to provide direct supervision. And again, this direct versus general supervision only applies to trainees and assistants. It used to apply to dependently licensed, but that has since changed. Thank God. All right, any questions about these terms and concepts before we start getting into some of the regulation changes? Okay. So all of the changes have been reviewed by the legislator, reviewed by JCAR, I believe is the organizational body that reviews all of the individual laws and regulations that go into the administrative and revised code and have been approved. So come January 1, these new laws go into effect. If you want to read them, the best place to go is the official site codes.ohio.gov/OAC for administrative code. If you do a Google search and put in Ohio Administrative Code, it will take you to this website as well. It is our responsibility as clinicians to know these rules and to have read the rules. So I will highly encourage you at some point in time over the next several weeks, get your hands on copies of these rules and read them. Now, part of the problems that we have been delving into in this process is that sometimes people are dually licensed, an RN and an LPC, for an example. And for the time being, the Department of Medicaid is saying you can only bill one of the licensees, either the RN or the LPC. You can't bill for both. But we have individuals in the organization who have these dual licensees that provide the two different kinds of services. So the Department of Medicaid has come up with a temporary fix using this H0004 code. So again, if you don't hold dual licensees, this will not apply to you. But it's a way around us to be able to bill for both kinds of services so that a nurse who provides a nursing service and then turns around and does some therapy can actually bill for both. Another change that came down the pike, because the changes have been occurring sometimes on an hourly basis, has to do with intensive outpatient and partial hospitalization. Just know that we as an agency are not going to be providing partial hospitalization services. So when we talk about the per diem for IOP, this is what is the only thing that applies under this policy update. But that, again, there were some providers out there that said, you know, we would like to be able to bill for services above and beyond the stereotypical IOP group. And originally we didn't have a way of doing that. We do now, to where on top of your standard group you could bill for individual services. You can bill for med-som services. This is an example of one of the recent changes that applies to all of us in the room in terms of the administrative code changes. This is the actual new law that defines what counseling and therapy is. And the biggest changes that went into or were going into effect is they delineate specifically that it must be face-to-face. That way there is no ambiguity whatsoever about providing therapy over the phone. And that it also can now include family members and the client or family members alone. In the previous regulation, we didn't have that option. Now we do. The other change has to do with group counseling, that it mandates that we can only have up to 12 clients in a group per one counselor. As soon as you get that 13th client, you must have a second counselor present. A new change that will be quite helpful for those of you who work with kids in particular is the ability to bill for family psychotherapy. That was not something we had the option before. So now we have these new CPT codes, the 908, 46, 47, and 49, that allows us to bill for true family therapy. I don't know about you, but I think this is a wonderful step forward. I previously have worked with teams that exclusively work with families, and they always had to bill everything under individual counseling. Now their service that they're actually providing matches the code that they're actually billing. This is one of the best examples of this National Correct Coding Initiative, where what you're doing matches what we're billing. With this service, at a minimum, it's 50 minutes. So rule of halvesies apply, meaning in order for you to bill for this service, you must meet with the family for at least 26 minutes. There's also new mental health services called therapeutic behavioral services and psychosocial rehabilitation. Between you, me, and the lamppost, I'm not quite sure what these services are. And you ask around, and there's a lot of people who aren't quite sure what these services are. However, in my head, how I try to wrap my head around it is this is very similar to CPST service. The difference is the provider must be an unlicensed service provider. So any of us with a license can never provide BH, TBS, or PSR. So it's only for those individuals who are unlicensed. Again, peer recovery support services are now a Medicaid reimbursable service. So again, this will be helpful for those sites who have peer recovery support specialists. Another new service that Medicaid is going to be paying for is psychotherapy for crisis services. I throw this slide in here just so that you know that it's available from the Department of Medicaid. It is not available to any of us in here because we as an agency are not certified as a crisis intervention agency. The only agency in town that's going to be able to use this is Crisis Intervention Recovery Center. But just know, as you maybe read more about BH redesign or see codes, know that this is codes that are now available, just not for us. So far, so good. Yes? All right. So now let's talk about some of the changes that are impacting the AOD side of our business. And that's primarily having to do with our residential services and IOP. One of the big changes that is impacting us and impacting everybody is the fact that now residential services and detox services fall under two different categories and two different sets of regulations. As of January 1, detox services will be classified as residential services. And all of the rules and regulations that apply for residential services now apply to detox services. So the Alliance Detox Unit, as of January 1, technically becomes a residential unit. The other element of the change has to do with what levels of ASAM level of care can fall under these new regulations, and that it's to coincide with level of care 3, and that level 3 providers can also provide level 2 withdrawal management services. So for RECOR, that provides the depth of services, these regulations now apply. The actual administrative code does a more descriptive job of what is expected of a residential treatment provider. And the biggest changes have to do with that a treatment provider must provide 3 meals a day that are nutritionally balanced and 1 snack every day. The clients must have the opportunity to get 8 hours of sleep. And the services are in a clean, safe, and therapeutic facility. That we must promote interpersonal and group living skills. The clients need to be connected with resources for education, job training, job interviews, employment stabilization, and obtaining living arrangements. A health history, including food allergies and drug reactions, shall be completed on or before admission. And if you're providing services for somebody who's a minor, they have to be developmentally appropriate. When it comes to level 1 ASAM level of care, that applies to what we provide in terms of TOP and MOP level of service. The codes that are going to be applicable for these groups include the 90853, the H0005, and the HK and AF. Now, you may hear finance people talk about modifiers. I don't believe, and correct me if I'm wrong, ladies, that they will not see the modifiers in the SIM codes. Okay. The modifiers and everything that goes along with that happens behind the scenes. So when you see some of these additional letters behind a HCPC code or a CPT code, just know that a lot of that happens behind the scenes and you won't need to worry about that. But the difference has to do with the level of the practitioner's license. We as billing providers must delineate how educated or the degree of licensure that an individual has on the claim. Because previously, there were different rates associated with it. So as an independent licensed clinician, I would get paid more than a dependently licensed clinician. That has since changed. The rates are now the same for the most part. Where the difference comes in is when you have a trainee or an assistant. Under those circumstances, if a licensed practitioner is not the one going out on the claim, we only get 72% of the rate. So one of the things that you will see as we start working through some of the pragmatics is that if you are facilitating a group with a trainee or an assistant, guess who all the billing goes out under? Pop quiz time. The highest credential. It will not go out under an assistant or a trainee because we don't get paid as much.
Excuse me.
Yes, sir.
Does that mean that the highest licensed person is the one that has to write all the notes then?
Yeah, right.
Unfortunately, I believe that's going to be the case. Because of how NextGen works, everything is tied to that provider.
Can you repeat the question?
The question was, who does the notes if you have a trainee versus a licensed provider? The answer is the licensed provider. Yes, Val?
If you're in residential treatment and you're going to be billing a per diem at 3.1 or 3.5, then don't worry about the supervision part. That's only for the individual group counseling and the outpatient.
Correct. This is only for this particular level of care. So residential falls under a whole different set of coding. Yeah.
So when you're saying the higher level, so the licensed professional is signing or writing the note. If that licensed professional signs off on the note, that's not, we don't get reimbursed for that supervision license. We get reimbursed for this.
The question is, if the licensed individual signs off on the note, do we get paid for that level of care? And I don't know if we have an answer to that yet. One of the things that has been frustrating for all of us trying to understand this BH redesign is when you ask certain questions, excellent questions like that, the answer you get is either, well, we haven't really thought about that yet, or it's very clearly described in the slides, please refer to slide whatever, and it's not referring to what we're asking about. So there's a lot of these unknowns that we're making our best educated guess on. That's why I said at the beginning that come January 1, as we start billing stuff out and realize, wait a minute, we're not getting paid for this the way that we thought we were going to, we may need to adapt and change. Hold on tight. As we know more information, we will be passing it out. Okay? So in this slide, if you look through this, this just gives an example of somebody who is in an ASAM level 1 care of service, and you have 6 different clients in the group, and you have 1 clinician, and the group meets for 3 hours. So it gives you the different examples of if somebody is there only for 2 hours, how you bill for the 8 units worth of service, where if somebody's there for 3 hours, we're billing for 12 units. But look down here at the bottom, somebody who is in the group only for an hour. Instead of using the H005 code to account for all of the time, your only option is using the 90853, which is for a unit of service less than an hour. This is why knowing what the codes mean and how they apply are going to be crucial for you, because you're going to see both of them as you write your progress note, and you'll need to know the difference between the two. And we're in the process of creating an overarching cheat sheet that will be distributed at our meetings next week so that you'll know what these codes mean. Here's an example where you have 2 clinicians, one who's licensed and one who's an assistant, and how the codes and the modifiers behind the scenes play out. So again, we as an agency are going to expect that the clinician who's licensed is doing the service and we're billing out under that individual.